Hello, my name is Isaac Bell. I'm currently a student at the University of Utah, an undergraduate student, getting my bachelor's in chemistry. I've been part of the bone and biofilm research lab for the past year, and I'm really excited to share with you the project that I've been able to help out with. And the title of this project is the development of a novel anti-biofilm polyurethane foam for use in negative pressure wound therapy. And this slide I'm going to share with you is the up-to-date current data that we have collected so far. And there might be a lot on the slide, so due to the nature of this presentation, feel free to pause the video and look at it because it's well worth your time. And I'm going to draw your attention to the specific key takeaways from each of the slides I want you guys to take away. So the problem and the background kind of we're seeing is biofilm causes 75% rate of affection in military negative pressure wound therapy. To understand this, I want to share with you what negative pressure wound therapy is. And so on the top left corner over here, there is a diagram of negative pressure wound therapy. There is the vacuum right here attached to a suction tube, and there is the foam right here. There's the seal, and there's the wound right here. So the goal of negative pressure wound therapy is to do one of two things. So the first one is to remove any exudates from the wound, and number two is to promote wound healing and closure. So here is a real life example of negative pressure wound therapy in action. You can see there's the foam, there's the wound, and there's the tubing with the vacuum. And so biofilm, we're looking at two specific biofilms in this project. The first one is MRSA, which you can see a picture of right here. The second one is Acinetobacter baumannii, and they're both biofilms. So if someone has a traumatic wound injury and they're taken into a hospital, the current standard of care, what they would receive, is either one of these two different kinds of negative pressure wound therapy treatments. The first one is polyurethane foam, and the second one's silver-coated foam. Polyurethane foam is really good because it's cheap and it's permeable due to low-density foams. That's why it's very common. And silver, which is good against antimicrobial. But what we'll see is I'll show you the data is silver-coated foams or polyurethane foam is not very effective against biofilms, which is why we're seeing the 75% rate. So the solution to this problem that was proposed in an earlier slide is to create a new antibiotic called CZ01179. Here is the chemical compounds right here and how to synthesize it. Here we ran a couple MICA analysis, and the first one with gentamicin, an antibiotic, we can see MRSA, and as well as pseudos 27853, that it takes about 250 micrograms per milliliter after about 21 days to eradicate it. And 250 is it's a lot. And so on the other hand, with CZ is we see it completely eradicates all of these except for pseudo. However, with pseudo, the most it requires is about 60 micrograms per milliliter, and then it drops straight down. 60 is a lot better than 250. And so what this means is these biofilms have a harder time of adapting resistance against CZ, which is what we want to see, versus here is these biofilms are getting a lot of resistance to gentamicin. And so the first aim of this project is the research and the development part with the in vitro anti-biofilm efficacy. So as you can see here, here's polyurethane. We loaded it with CZ on the other hand. That's what it looks like. We ran an elution kinetics. And so we did 3 different tests on a 2.5% weight to weight, 5% weight to weight, and 10% weight to weight. And here's the chart for over an hour. We can see that it's still releasing CZ from the foam. And we ran a test based off that. Here's the setup right here. You can see the foam right there. We ran it for a while. We used collagen plugs that's been loaded with bacteria with either MRSA or Acinetobacter. And here's the results right here. This is what I want to share with you guys right now because it's really cool what we saw. And so I just want to draw your attention to silver, which is right here. We only saw 10, about a half a log reduction. With CZ, completely eradicated it. We weren't able to detect any growth against Acinetobacter. Same with MRSA, on the other hand, with the 10 weight to weight. Yeah, and the silver hardly eradicated the biofilm. So with that, an aim, which is to do an ex vivo anti-biofilm efficacy test. And what the purpose of this is to kind of design what our in vitro setup is going to look like. And so to start with that is we took some pig skin, 4 by 4 centimeter wounds. We inoculated with MRSA or Acinetobacter, and then we put the foam on top of it, either silver foam, polyurethane foam, or either CZ foam. And then with that, we created a seal, the tubing around it, and then we hooked up the suction, and then we ran it for 48 hours after the initial inoculation. We did one punch in the corner so we could run tests on that, see how much biofilm we were able to detect. And then we did the remaining 3 corners after 168 hours or 7 days. And I'm excited to show you the results here now. So the results from this test is, I just want to again draw your attention because there's a lot of data on here between silver and CZ, these two left right columns. And so with silver against MRSA after 24 hours, we saw pretty much not a very much of a log reduction, whereas CZ we see an immediate 2 log reduction just after 24 hours. We're already seeing it come into effect ASAP. And so after 72 hours, we see a 3 log reduction, whereas silver is still about a 1, not even a 1 log reduction. And then after 7 days is we see a 4 log reduction, whereas silver hasn't even done much at this point. So now, Acinetobacter against the other biofilm that we're testing, silver has no effect at all, whereas CZ, on the other hand, right off the bat, has a 4 log reduction after 24 hours. After 3 days, we see still 4 log reduction, while silver has about a 1 log reduction. It's catching up. But after 168 hours or 7 days, we see a complete eradication. We can't even see any biofilm, Acinetobacter, left on the pig skin. Whereas silver, we see about a 1 log reduction. So these results are what we wanted to be seeing. And this leads us to the next number 3, the in vitro anti-biofilm efficacy test. And so the main setup with this is we put the pig under anesthesia. We do surgery. We create 2 4 by 4 centimeter wound beds into the apaxial muscles of the pig. And then that's day 0. And then for the next 3 days, day 1 through 3, we inoculate it with either MRSA, Acinetobacter, or natural flora. We don't even inoculate it at all. We just let the natural flora take over. And then after 3 days, we do the setup like in the in vitro setup, very similar. The jacket holds the vacuum. And after 7 days of treatment, or a 10-day period, after 7 days and 3 days of inoculation, we harvest the pig skin and we quantify the data and look at them. So this is kind of like our protocol that we've been approved by IACUG, and essentially there's 3 different biofilms groups we're doing with 4 control groups within. So we're either having a negative biofilm, positive MRSA, and positive Acinetobacter. And I'll show the data that we had so far up to date. So the first group we're going to look at is MRSA right here. So this is the graph for the wound reduction of MRSA from the beginning to the end. And I just want to draw your attention to the wound reduction percentages. This is the average of our study so far. So we've done a couple pigs within each of these groups, and this is the average. And so with positive MRSA, positive negative pressure wound therapy, we see a 24% wound reduction, whereas negative pressure, with none of it happening, we see 19%. So there's a 5% difference there. And so that's kind of like what we've been hypothesizing is negative pressure wound therapy helps promote wound closure and reduction. And here's the cool graph I like this, the biofilm efficacy versus MRSA. And so as you can see that inoculation is about 10 to the 10. And with CZ, we saw about a 5 log reduction from there. And again, I want to compare it to silver because that's kind of what the standard of care is. We see about a 2 log reduction. And so we see almost a 3 log reduction difference, which is a big deal when we're dealing with biofilms to prevent the damage biofilms could cause. And so here's another perspective of how well CZ has been doing. And so this is CZ plus negative pressure wound therapy. You can see right here, the 4x4 centimeter wound bed. This is day 1 of treatment. You can see the MRSA on top of it, and it's very smelly and it's gross. After 7 days of treatment with the CZ, we don't see much of it, and it's not as smelly as it used to be. Next, I want to talk about the Acinetobacter data. And so again, here's the wound reduction graph. The wound reduction percentages, again, with negative pressure wound therapy, we see 28% wound reduction versus 6% without negative pressure wound therapy. And this is a pretty big jump right here, big difference. So now onto the anti-biofilm efficacy. Here's the inoculation, about 10 to the 9. And then we see about, a 5 log reduction with CZ after 7 days of treatment versus silver, which only has about a 2 log reduction. Here is day 1 of CZ with negative pressure wound therapy and day 7 of CZ with negative pressure wound therapy. You can see the Acinetobacter biofilm is pretty gnarly, pretty nasty. And then after 7 days, you can kind of see it cleans it up really well. And so now part of my UROP experience was to calculate the wound size of these pigs. So I want to share that with you real quick before we move on. So as you can see, there's the ruler on the side. From one line to the next line is 1 centimeter on that ruler. And so I use this program called MHJ. What MHJ allows me to do is to create a line that tells it it's 1 centimeter. With that being said, I drew a line all the way around this wound, and with that 1 centimeter line, which tells the program that's how many pixels equals 1 centimeter, I'm able to create the size in centimeters. And so that is how I was able to create the data for the wound reduction percentages you're seeing here. And now the last I want to talk about in our project that we're experimenting is no biofilm, just the natural flora. And so again, you can see the wound reduction percentages. We saw 47% with negative pressure wound therapy, wound reduction, and then with no biofilm and negative pressure wound therapy, we saw a 7% reduction. On this part right here, with the biofilm is CZ, we saw again about a 4 to 5 log reduction, whereas silver, which is right here, we only see about a 1 log reduction. So we can already see from these charts, from our analysis, our results, and our data, that CZ is doing a lot better of a job than silver, which is the standard of care against biofilm. And this would very much help out with the problem that we're seeing in military negative pressure wound therapy treatments. Here's day 1 of CZ plus NPWT. It's kind of gnarly from the natural infection. Day 7 does a really good job of cleaning it up. So in conclusion, to kind of wrap this up, we established a baseline for wound reduction, and we're continuing to do so. And we've been seeing statistically significant results for the efficacy of CZ. And we're seeing that with the current pigs that we have seen in the past, and we're continuing to see in it 4 to 5 log reductions. So in the future, moving forward, we want to create more data points for the wound area and the CFU. per gram results. And we want to try different kinds of wounds, like on the legs, different areas, 8 by 8 centimeters. Here's my project I'm working with, and thank you so much for listening to this presentation.